he's going live.
Great, and it'll come up 5, 4, 3, 2, 1 or something, and then you can start. That's it.
Okay.
Craig Rubinstein is now live.
Are we on?
Hi. Yep, you're on.
Okay. Hi, Craig Rubinstein. So, taking questions. We don't have any sound. Yeah, volume's up. Okay. All right. This is Craig Rubinstein. This is the first one of these I've done. So hopefully I can provide some information, help some people.
There might be some lag.
Okay. I can't hear anything. Oh, good. Sounds like it's now working. So if anyone has any questions, please feel free to ask them. Just for the record, I've just finished consulting. We've seen, about 60 or 70 patients today. And I'm operating tomorrow. But anyway, if I can answer some questions to help people, I'd be more than happy to do so. And it looks like Emmy's on and Nadia's on. Hello, Nadia. Hey, Emmy. And you can hear. I can't hear you guys. I'm not sure if I'm meant to be able to. So maybe just send me some questions and I'll answer what I can for you. Okay, all good. So just briefly, I'm a plastic surgeon. I have been in private practice for 20 years and my only practice is now breast and tummy. That's all I do, just women. So if anyone wants to ask anything, please feel free. Hi, Emmy. I can see you there. Hello, Julie. Hello, Melissa. Now, Melissa's got a question. Could you tell me if tummy tucks will help reduce love handles? Tummy tucks range from very basic to quite extensive, but in a tummy tuck that's done properly, there's liposuction to the upper central abdomen, there's liposuction to the mons, that's down south, there's excision or cutting out of the extra tissue and repairing the muscles, and usually liposuction to the sides as well. So it doesn't always correct tummy love handles, but if it's done correctly, it should significantly reduce them. And if that's a particular emphasis, then that can be done as well. So the answer is, in a long-winded way, yes. From Ren's Bell, what are the general procedures included in a mummy makeover? So just for the record, I'm not really struck on the word mummy, but as it's currently understood, it's a combination of surgeries in women who have had children and want to be as they were before. So it's a combination of either breast reduction or breast lift or breast augmentation or combination of lift and implants. And so it's breast surgery in combination with abdominal surgery as a general rule. Hello, Jane Elizabeth. Okay, so I've been given a list of questions which I'll go through and hopefully these are helpful. I'll go through them fairly quickly, but if anything's not clear, please ask me because I want to cover quite a few things. Why do some surgeons perform more than one procedure at the same time and others don't, and which ones do you do together? That's a very good question. I frequently do perform procedures together, but as I tell all my patients, there's only one thing more important than their happiness, and that's their safety. So for me, a breast reduction or a breast lift with augmentation or a breast augmentation takes me between 1 and 2 hours, and an abdominoplasty takes me 2 hours. So if I do the two together, it's generally 4 hours. So my line in the sand is I won't generally operate more than 4 hours because I think the risks of a surgery less than 4 hours are probably fairly good, but beyond 4 hours, those risks increase. And also the truth is after 4 hours of operating as a surgeon, I do get a bit tired. So 4 hours is highly acceptable. And without rushing at all, 4 hours is usually more than enough to do most of the surgery. Sometimes I go back and do some secondary surgery, but most women want the surgery done all at once because it's one recovery from a financial point of view. So we do try and do the two together. If someone has extremely large breasts and a very, very big tummy, then I generally recommend to do them separately. That way I can do more work on one, get a better result. And when I go back into the second, I can even come back and do a little bit of revisionary surgery to the first. So it's really a matter of time and safety. It says breast lift. I'll just clarify, all breast reductions include a lift and all lifts include a reduction. So the two go hand in hand. Now, having said that, a reduction can have a small lift, a big lift. I mean, most people obviously want as much lift as possible. And some lifts also involve a little bit of reduction, but a lift is really mainly skin with a little bit of tissue to get contour. Hey, Amber, I can see you're there as well. So all reductions are lift, all lifts are reductions, and that's both aesthetic in that it looks better, but it's also functional because a droopy breast has to be lifted in a bra, which can swap the pain and problems of a large breast to the shoulder and the neck. So it's a combination of looking better and being safer and getting rid of the neck, back and shoulder pain that are often attendant with droopy or large breasts. What are the pros and cons of doing more than one procedure at the same time? Well, the big pros are get everything done at the same time, but one of the things about plastic surgery is convenience is only a very small component. There are much, much more important things, and safety and getting a good result are more important. So whilst convenience is not irrelevant, because we live in a real world, safety and getting the best results are much more important. And I'm a very conservative plastic surgeon, but I do literally thousands and thousands of procedures, and there's a good reason that why we're conservative. Now from Emmy, I've got, how do you reduce the risk of wound openings after surgery, please? Are certain people more at risk? A wound opening means that the tissue tension is too great for the wound to close. So there are reasons why people have wound openings. It may be a technical error that too much tissue is taken, or the wound has been closed too tightly, or it has been closed too loosely, infection, excessive undermining with liposuction. So it's a judgment call to take the right amount of tissue. Now, in being conservative, if you don't take enough tissue, you won't have a wound opening, but you won't get a good result. So it's a judgment call. And really, it's an interesting question that, you know, when I was a trainee, I was always asking, why, how do you know how much to take? Because I wanted to know exactly. And the answer that I was always given was, you take what's right. And it was an answer that I hated back then. That was 30 or so years ago. And now it's the answer that I give. I take what I think is safe and appropriate, and it's based on probably literally hundreds, if not thousands of procedures. Also making sure that patients don't smoke for prior to surgery, that they're done carefully, properly, well hydrated, good anaesthetist. There are a lot of little things that go into it. And it's really surgical technique, gentle handling of tissue. So there are a lot of, probably hundreds or dozens of things that go into things that make it look easy. Do you recommend any particular supplements to help support the wound afterwards? We actually do. As part of our protocol, we provide everything. So we actually provide a rapid recovery pack, and that rapid recovery pack has protein supplements, it has arnica, it has lactobacillus so you don't get thrush. We also do give dietary advice if it's appropriate. So there are a lot of things that go into that. In terms of supplements, I think we also provide a broad a multivitamin. I'm not generally a fan of excessive supplementation, but I think with surgery it's a good idea. So we just make sure that your base nutrients are appropriate, magnesium, all the other things like that, zinc, iron. And if there are special cases, we can give more things as well. We try and customize it for every person. I'm scared. Now, third question. I'm scared I'm going to lose the sensation in my nipples after a breast lift, and why do some people lose it and others don't? Is the particular technique. I tell all my patients that in surgery it is possible to lose sensitivity in the nipples, because although the anatomy of sensitivity of the nipples has been well described, it is variable. But as a surgeon who I guess obviously performs lots of these, I try and preserve the tissue where the nerve is going to be to minimise the chance of that happening. For some women, they actually don't lose sensitivity, they can actually get increased sensitivity. And that increased sensitivity is not a good thing. It can actually be hypersensitive. What we find with most people is that although there is initial decrease in sensitivity, it usually returns to normal, but not always. And what I tell all my patients is, If you're not prepared to accept that risk, then maybe surgery is not for you, but the likelihood is fairly low. So with most questions, the answer is never it's impossible, but it's very unlikely, particularly if it's done carefully and properly. Now, conversely, if someone's having a massive breast reduction, and that can be of, I've taken up to 5.5 kilos, then the likelihood of losing sensitivity is greater, but conversely, those women often don't have a lot of sensitivity. So it's a personal thing. It needs to be assessed on a case by case, but I also say I don't believe I've ever caused any woman to lose all sensitivity in both nipples. Maybe I haven't, they haven't told me, but I don't believe so. So although it may occur, it'd be fairly unlikely. In fact, I've just got a comment here that someone in fact did get hypersensitive and they returned to normal after a while. And I think that's not an uncommon phenomenon. So that is quite possible. But again, with plastic surgical technique, gentle handling of tissue, respect of anatomy, not performing excessive surgery, doing the right surgery for the right person at the right time for the right reasons. In terms of particular technique, I think there are technique variations, and it's also surgeon variations and patient variations. So, for example, in breast lifts and breast reductions, I no longer do the anchor technique, or I no longer do the inferior pedicle, which is where the nerve supply comes from below, because I think it's more reliable from above. So I won't go into too much detail because I could talk for hours on it, but the technique I do for all my reductions and lifts and have for more than 10 years is what's called a le jour or a lollipop technique. And I can go through that in detail if I've got more time. What happens if I get pregnant after abdominoplasty? That's a very good question, because that is a possibility. It's interesting, I have, again, not exaggerating, probably performed hundreds if not thousands of abdominoplasties. As far as I know, I've only ever had 2 women who did get pregnant. And as I tell women, if you do get pregnant, it's not in any way dangerous. It'll just stretch up as it would for a tummy that hasn't had surgery, but it could potentially undo the good work. Now, having said that, of those 2 women who came back to me after having had pregnant, one of them was actually had a good result, so she didn't stretch up, so maybe in reinforcing the muscle it gave her a bit of protection. And the other person, I think, was going to have some minor surgery, and I don't think she ever proceeded. So I guess the advice I would give any person considering abdominoplasty, if there's a reasonable or high likelihood of becoming pregnant, then I think it'd be common sense to defer surgery. Will it be necessary or even possible to have another one? Again, I try and speak from experience, not theory. In the many I've done, I've never had to go back after someone's got pregnant. So maybe they've got pregnant and gone elsewhere, but I believe and hope that patients always come back and see us because we do the right thing and look after them. If you've had muscle repair, does it need to be unstitched or whatever when you get pregnant, or does it just tear again or what? No, it doesn't need to be unstitched. In fact, I don't think it could be unstitched. It doesn't tear, it's just everything stretches up again, which is the whole way the female tummy's been designed, I guess, is so it just stretches. But again, I don't think that's a major issue. What's the recommended time off work for a mummy makeover? Well, the first question I'd always ask is, what sort of work do you do? Some women say, look, I don't work, I'm just a mother. And I don't laugh, but I think I'd much rather be a surgeon than a parent. It's much easier, although I actually am both, because being a mum is a full-time job. But in terms of physical work, you won't be back at physical work for, I say 3 weeks, give or take a week. So it could be 2, could be 4. If it's very physical work, say, I can't think of an example, but I think I had someone who was a stevedore, was lifting steel pipes. I think it was 6 to 8 weeks. But generally 4 weeks, give or take, or 3 weeks, give or take a week should do it. Again, if it helps, we actually provide a certificate. It doesn't say what you've had done, it just says medical condition, because it is a confidential document and it's not for disclosure. In terms of picking up the kids, which is the commonest question I get asked, is I say, look, you're going to do it anyway, so just do it. You can actually pick your children up the next day, but again, common sense. So get them to jump up and just lift them carefully, and don't sort of throw them up in the air, which you probably wouldn't do anyway, and get a bit of help from your partner if you can. Again, if you are self-employed and work from home on a computer, you can do a little bit of work the next day. If it's physical work and you've got to drive an hour each way, then you might take a bit longer. It really depends from person to person. It depends on surgery, it depends on recovery, it depends on the size of the surgery. So although it's not a specific answer, there are guidelines. In terms of driving, it's really, there's no medical reason you couldn't drive within a few days, but common sense and insurance says you won't be driving for probably a week or 2. Most people are driving within 2 weeks. They probably most at 1, but it's really just traffic and safety. What else is there? But in terms of getting up out of bed, you need to get up out of bed the next day. You can walk around like a little old lady, you'll be bent over, but you can have a shower, you can wash your hair the next day, you can have a cup of tea, you can have a glass of wine, not that you might feel like it, but you can. Now, the next question is, what compression garments do you use for a mummy makeover? It's interesting, I've been reading some of the forum questions, and a lot of women have been asking, where do I go and get my garments, where do I get my bras, where do I get my girdles? I think that reveals a lot about the surgeon who's looking after you. In our practice, that's cosmetic surgery for women, we've got 5 surgeons who all specialise. We provide everything. So we actually provide the first 2 comfort bras, we can give you the first 2 sports bras, we give you the girdles, and if they don't fit, we replace them, we provide the laser, we provide everything. So I don't really think as a patient it's a good idea that you're running around buying and getting things. They should all be provided for you. And look, I mean, we are a premium practice, but we provide absolutely everything, which means you don't have to worry about anything. We provide the laser, we provide absolutely everything. So in terms of compression garments, as I said, for breast, the first week it's just a comfort bra, which really doesn't do a great lot. And then after that, we can give you 2 sports bras, and sports bras are important, which I can talk about later. In terms of the tummy tuck, we provide a girdle. Sometimes we provide stockinette or various other things, but it really depends. We try and customise, but it's all included. Now, Tarn, darling, you've just called me the best surgeon in Australia. I think you're under drugs and you're biased. I will take the compliment, but thank you. What's the best scar treatment? Again, it really depends on what kind of scar you've got, your skin type. There are a lot of different factors, but again, we have a very, I'm not trying to self-promote, but this is just what you should get from any surgeon who you go to. We've got a whole protocol of scar management. We've got Fraxel, which I think was about $150,000, and it's a dedicated laser for scar, and that's all included and provided. We provide at least 3 treatments, usually more, or frequently more. We have a number of dermal therapists who do dermal penning. They do, I mean, there are things actually, truthfully, I don't even know what they do, some of them, but it's all provided. So scar treatment is a combination of probably choosing the right surgeon, doing the right surgery, and then, you know, good treatment, good intraoperative management, being advised what you can and can't do post-surgery, laser. We provide a lot of tapes. I'm a big fan of tape because I think what they do is they protect the wound, because where there's tension, there's going to be scarring. So firstly, good surgical technique to minimise tension, but then taping to preserve skin edging. Now, there are more questions. Strong painkillers, absolutely essential post-surgery. Look, that varies from person to person. And one thing I've begun to realise, every time I think I've figured out someone proves me wrong. Some women actually require almost no painkillers whatsoever, and some require a lot. But we now understand pain a lot better. And one of the things that we do is, whilst you're asleep, I put a lot of local anaesthetic in. So I actually do a bit of a block. I put local anaesthetic into the muscles of the tummy, into the muscles around the breast. So the aim of surgery is that when you wake up, you actually have no pain at all. Now, I don't guarantee that because it varies, but we've actually had a number of women who've woken up and didn't even know they'd had surgery. That's not common, but it happens. We've had some who have been miserable as well. So what we like to do is, if you can wake up with minimal or no pain, and then you're given regular painkillers, and hopefully we can avoid strong painkillers, because all drugs have side effects, they'll have complications, and if we can minimise that, it's obviously in everyone's best interest to do so. But again, it's like having childbirth. Some women go completely natural, whatever that means, and have none, and some require cesarean sections, run digital blocks, or not digital blocks, spinal blocks and everything. But again, the other point too is we have really very experienced, superb anaesthetists. They've all been with me 10, 15, 20 years, I think now 15, 20 years, and they really look after you. So we want you to be comfortable, because we want you to be comfortable, but also if you're uncomfortable, then your blood pressure can go up, you can bleed. So there's a lot of good reasons why we want to keep you warm, we keep you comfortable. We actually want to be a really pleasant experience. I mean, it's surgery, we want to be a pleasant experience, because it's just a nice thing to do, and B, if we look after you, who knows, you might even suggest us to other people. Now, Liam McKenzie said, where am I located? We have, my practice is in Hawthorn, so that's in Melbourne. And we have a number of surgeons who are in Berwick and a few other different sites as well, but Hawthorn. And it's, I actually have patients come from interstate and overseas, which is not necessarily the good surgeons there, but people do that as well. Karen Maloney, there's been much discussion on this forum about drains versus no drains. Okay, well, again, all I can do is talk from personal experience. For breast reduction, somewhere between probably about 12 years ago now, I stopped using drains completely, and my incidence of hematomas has been not zero, but almost zero. So I have stopped using drains. The problem with drains is they're painful, unpleasant, they're uncomfortable, they increase infection, they give you a scar. Women hate them, and I'm supposed to take them out. So with very few exceptions, and I do occasionally for breasts, I haven't put them in for about 12 years. And interestingly, I think it was about 2 or 3 weeks ago, in 2 days, amongst other things, I actually did 5 breast reductions, which is a lot. For me, it's a lot anyway, 5 in 2 days. And I didn't use a single drain, and we didn't have a single hematoma. And there was another surgeon who was very junior. He used the old anchor technique next door, put a scar, which I don't think he should have. He put a drain in, and I heard my nurse was called in at 1 o'clock in the morning because he got a hematoma. So I'm not sure drains prevent hematoma. I think good surgical technique does. Compression garments versus no compression. Look, I don't feel strongly about it. I think gentle compression makes you feel better and might help. But really, you can't put very, very strong compression, particularly with a tummy tuck, because it's just going to squash inside, and that can actually cause problems. And I've actually seen problems from excessively tight. So comfortable and sensible is the way to go. Outcomes seem to be the same regardless. No, I'm actually not sure that's true. I'm not sure that's true. I think the drains are, look, I think the instance of complications, if it's done carefully, is very, very low anyway. But I think if you do need a drain, you do get one. But again, for breast, none for 12 years. And for tummies, I've actually stopped doing them for the last 2-3 years as well. And I can't say I've had no hematomas. I've had 2. Both actually needed to be drained, although that was done on the ward. So drains do have a role, but again, they should be used selectively and carefully with experience as opposed to with everybody. I've just had a lower body lift and had none. It's possible. Yeah, totally. I mean, again, as I say, Emmy, I completely agree. I think drains are only in certain circumstances. With good surgical technique and a compliant patient, most of you should not need to have a drain. So, good point. Philomena said thank you. I'm not sure what for, but hopefully I've helped you. Leah McKenzie, what is your website? We've got 2. It's plasticsurgeons.com.au. That's plasticsurgeons.com.au. Don't forget the AU, or you'll go to somewhere in America. Or CSFW, or CS4W, I think it is. I should know these things. So it's cosmetic surgery for women. So it's cs4w.com.au. And what else have I got? Leah McKenzie, what is the cost for initial consult? I think it's $200. I should know these things. I think it's $200. And if it is a medical condition and you have a referral letter, $67 back from that. I don't do free consultations because I think if something's important enough, then it requires some input and some contribution. And I think also when things are free, they're not appreciated. But we provide very, very good value. And my philosophy is that the first consult I charge, I actually don't charge for further consults or reviews. And I've been seeing people from now for 20 years, but I don't charge. And the reason I don't is because I want people to feel free to come back anytime they want to. I like seeing them, and it's good for my patients, good for me. I'm now literally seeing patients 20 years down the track, and it's just good medicine. Nadia, oh, there we go. She's put them up. So it's www.csfw.com.au or www.plasticsurgeons.com.au. Nadia, you are the greatest, but you already know that. Emmy, sorry, I meant no painkillers. It was from your answer to whether they are necessary. I had a lower body lift and no painkillers. Emmy, you are amazing. You should go on MMA or something like that because that is fabulous. So I'm very, very impressed. It is possible. Good for you. Well done. Leah McKenzie says thank you. And what are we up to now? I've seen another question. I've seen a lot of different scarring with tummy tucks. Does it depend on the surgeon and how we can ensure it's minimal? I think it absolutely does. Now, it's interesting. I've been to conferences where they do tummy tucks with what looks like a bicycle handlebar scar, and I've never understood why they do it, because nowhere in nature, except on a bicycle, do you see a handlebar. So I try and put a nice low curve, and I try and put as low as I possibly can, so it would hopefully sit within bathes, bikinis, jeans, or an outfit. What I do tell people, if you're wearing G-string or walk around the house naked, it'll show, but I also qualify most of the women I look after tend not to walk around the house naked or in G-strings after a tummy tuck. Which is a pity beyond the scope of this conversation. But yeah, surgeon choice is critical. Scar treatment, I think I've answered. I had a breast lift about 10 years ago, but they've dropped and are really heavy at the bottom, but my upper pole is empty. Yeah, there are a combination of reasons for that. I'd be very interested to know if you had the anchor technique, which again I stopped doing 10, 12 years ago, or more actually, or the lollipop technique. So one of the criticisms of the anchor technique, in addition to the unnecessary scarring, which is a biggie, is they do tend to what's called bottom out, so you do get that. With a lollipop technique, because the breast is held from above, it can occur, but it's much, much less likely. So that could be the surgical technique. It could be weight loss. It could be your skin. It could be a whole lot of factors. Do I have to go under the knife again? You don't have to do anything, just how much it worries you. But it can be redone if that's the question. I feel the scar tissue all along the ridge under my breast, so I presume I'd need a scar revision there. Anyway, it's horrendous. But it sounds like you had the old-fashioned anchor technique. And again, there's nothing wrong with the anchor technique. It's just I personally don't like it because I just think there are much, much better techniques. And my personal thing is that why would you do an anchor technique when you don't have to, when there are better techniques? And maybe some people don't know how to do it. Maybe they know something I don't, but I don't. I think an anchor technique is, in most cases, an obsolete technique, and I wouldn't recommend it. Nipples quite high. Yeah, nipples high is a technical error, and it's usually that a nipple should be at the point of greatest projection on the breast. So a high nipple can be a bit of a technical error. It used to be said it's not correctable, and in fact it is correctable. And I've actually got a reasonably straightforward way, which is pretty reliable. It's to take a big ellipse of skin, which does give you a bit more scarring, but it is correctable these days. But the best way to correct is to not cause it in the first place. How long under anaesthetic do you have a breast augmentation and a lift? It's usually a little bit less than 2 hours. I might spend half an hour marking and preparing. So what we do is we spend a lot of time preparing and drawing and marking. I use a laser level and photograph it. So the actual asleep time is minimised, but we never ever rush. We've got very, very good systems. But now when I was taught to do a breast reduction 20, 30 years ago, they used to take 4.5 hours. Now we take 2 hours and we get better results, but we've got better systems. We do a lot of them. Now I've got a few more questions. What have we got here? From Julie, I had a lollipop and it's dropped out. Don't know, Julie. Maybe I can have a talk to you if you want to come and see me. Hopefully, I didn't do it, but come and see me because it is possible, and it can be your tissue, it can be the surgery, it can be a whole lot of factors, but that is correctable. So that elliptical excision, it actually works really, really nicely. I do quite a few of them. I do them on I do a lot of secondary surgeries on other people's surgery, but I also fix up a lot of mine as well. And it's probably a two-way street. So a good surgeon will do that, I think. From Donna, for arms after weight loss surgery, is that considered reconstructive and covered? Is there any criteria? I believe it can be, but I don't know. I'm not sure that I can answer that question because the only thing I do is breasts and tummies. So I could probably find out for you because I do have surgeons who do arms and thighs. I don't do them because you just can't specialise in everything, and I really like to just do a few things and sort of do them to I would hope, be pretty high level. So I don't know, can't tell you. What sort of price is a full body lift? Again, I actually, it sort of sounds weird, I don't really do body lifts per se, but I do a lot of tummy tucks. It's interesting, I've had quite a few patients who have been elsewhere and they've talked about, they've been booked for a body lift or whatever, and for whatever reason they've come and seen me. And I said, why would you have a body lift? You get a lot of scarring, which is pretty unattractive. It can take 4 to 6 or 8 hours. It's got a very high rate of complications. And most people, some exceptions, actually don't, I believe, need a body lift. We do the tummy. That gives them 80, 90% of what they want or more. And then we can always go back and do a bit more later, which rarely we do. So I'm not a fan of body lifts. I'm very conservative, but I'm conservative for a reason. I think safety is more important. 40 kilo weight loss. Again, you may need a body lift, but if you can avoid it, it's always worthwhile. And sleeve surgery, gastric sleeve surgery is a fantastic procedure. I mean, I've looked after people who have lost literally 90 kilos, in fact, more than most people weigh, and we've still just done tummy tucks and still got good results. And Julie says, no, I didn't do it. Good, I'd be a bit disappointed if I had. It's 12 years old. Look, Julie, it's a bit hard to say, but if you want to come and see me, if it works out for you, you can send me some photos. I can hopefully give you some comments. But it might not be anyone's fault. It might be just gravity or time. So I don't know, but it probably is fixable if that's important to you. And from Donna, come and see me. Yep, good. Leah, thanks for answering. I hope I have. Emma, why didn't I come and see you first? Well, I mean, even if you saw me, it doesn't guarantee you get a good result. but I think we do pretty good quality work. We stand behind what we do. And no one gets it right first time, every time, me included, but we follow up what we do. We go in, and if people need secondary surgery before it's worth, I include that. So I don't know, but hopefully you've still been looked after by your surgeon. From Trish, my opinion with body lift, just because it can be done doesn't mean you should do it. Yeah, I think that's a really good point. And we have an expression, in fact, I've got lots of expressions, is just because you can do something doesn't mean you want to. Just because you want to doesn't necessarily mean you should. So it really it depends on what you want, your body, your recovery, your circumstances. You know, if you've got, 3 or 4 kids and, there's just no way that you can be out of action for 6 weeks or 8 weeks. So it needs to be catered to the individual, to the anatomy, and a whole lot of things. From Julie, thank you, my pleasure. From Beck, I'm struggling to see how after 90 kilograms, there wouldn't be back fat or rolls of skin sitting on hips. Yeah, I think you're absolutely correct, and I think there probably were, but the higher priority was to do the surgery safely. And in that particular person, it was a massive abdominoplasty. I mean, huge. And look, basically from a safety point of view, I wasn't prepared to do any more than that because I wanted my patient to survive. And look, the truth is, it was probably more than 15 years ago. It was a long time, but I think I actually have lost track of them, but they didn't come back to the back. It was the tummy that was their particular problem. But point taken. With your tummy sucks, do you do FDL? I'm sorry, I don't know what that is. What's FDL? And whilst I'm waiting to find out what FDL is, some people, when they do a tummy tuck, just remove a bit of skin. Oh, fleur-de-lis. Yeah, fleur-de-lis, it's actually pronounced fleur-de-lis of all things, interestingly. That's the correct French pronunciation, but fleur-de-lis sounds a lot nicer, so I think I'll call it fleur-de-lis because that's how I was brought up on. So fleur-de-lis is where you do a big horizontal excision, but you also do a vertical excision. So it's a 3-point star. I do them very, very, very rarely, and the reason being is when you get a 3-point of contact, it's usually got a poor blood supply. It gives a very unattractive scar. There's a high likelihood of wound breakdown. So yes, I do them, but that's very uncommon because what I found is doing the abdominoplasty, particularly in combination with upper abdominal liposuction, if appropriate, and where else, frequently I've been able to avoid it because that fleur-de-lis scar, and the tummy tuck scar will usually hide under reasonably conservative clothing. But if you've got a vertical scar that goes from the mons all the way up to between your breasts, there's no way you can ever hide that. So it is a trade-off. Of all the tummy tucks I do, the number of fleur-de-lis I do is probably, I'm going to make a guess, less than 1 or 2%. Any more questions? So again, as I was saying with tummy tuck, some people just cut a bit of skin and call it a tummy tuck. But if you're going to do it properly, and again, it has to be appropriate, but to do it properly, it's really as much skin as safe. It's really repairing that muscle. And I've got some spectacular photos. I take a lot of photos of the markings, which you're welcome to have. I actually use a laser level. I check into everything. In surgery, I actually take photos. And what I like to do is I mark out the split in the rectus musculature. That's called a rectus divarication. That's the split in the muscles. I actually draw it with a texter, take a photograph. Then I take a photograph when it's half been repaired, then take a photograph when it's fully repaired. And when I show patients, they go, "Oh my God, that's disgusting. Can I have a copy?" So it's quite fun. That's how surgeons have fun. But actually, when you're not my friend for a few days and I show you the photographs, you go, maybe that's the reason why. But so there's doing that. And again, some people get a good result with one-off. Some people need a little bit more surgery. But I like, if it's appropriate, going back and doing a little bit more if people want it, because just gets a better result. And that's the aim, safety. From Joan Liz, do you have surgeons in your practice that do arms? We do. We have Jeff Barnett and Richard Maxwell, and that's what they do. So, and they're very careful, precise, very obsessive. And it's interesting with being a plastic surgeon. I mean, I love being a plastic surgeon; it's my passion. But being a plastic surgeon means being precise, careful, accurate, taking it very slowly, never rushing, and getting it right. And I actually have seen surgeons who have been casual, and it's bad. It's not good. So whoever you go to, you want something that's going to be a little bit painful. And when I say painful, I mean pain, but they're going to be careful and do the right thing. And this is from Tegan, who says, I couldn't recommend Craig highly enough. Ladies, I have surgery with him in May. I wouldn't trust anyone else but him with my body. Tegan, I'm sure I must have paid you to say that or something, so thank you, darling. I really much appreciate that. Nice comment. So I'll take the compliment. Well, that was a nice way. Anything else? Any other questions? Now, please excuse me, this is the first time I've ever done this, so I hope this format is helpful, but hopefully you can actually see me because I've got all this writing across the screen, so I think this is what I'm supposed to be doing anyway. Beck, who is back to the discussion of tummy tuck and back fat, would you choose full body lift, send elsewhere, or would fleur-de-lis be suitable? Beck, look, it's a great question. Obviously, it's a personal one to you. I really do. I only do a certain number of operations, but obviously I do a lot of them. If I thought you needed a total body lift or back fat, I would refer you to one of either Jeff Barnett or Richard Maxwell, and that's what they do, and they do a beautiful job. And it's not that it's not a good surgery, it's just that I like doing what I do, and I love doing breast reductions, I love doing breast lifts, I love doing breast augmentation, I love doing combinations of those, I love doing tummy tucks, and that's what I do. So yeah, but we do have people who specialise in these things. From Jane, thank you. And Julie says I'm doing okay. Thank you, Julie. I hope that's correct. Beck, you're doing great, very helpful. Cool, this is all good. I hope these probably all right. And Emmy, thanks for your time. It's been great. Well, look, I hope that has been helpful. If anyone wants to contact me, they're very, very welcome to. If they want to make an appointment, then they're totally welcome to. And again, we don't pressure people. I very much subscribe to it's the right person having the right surgery at the right time for the right reasons. And not everyone chooses me as a surgeon for all kinds of reasons. That's not a problem. I'm not the surgeon for everybody. But if you want me to look after you, I want to look after you. There's only one job we do. That's the absolute best we can. Now, I've been told I'm going to go overtime and I'm going to get in trouble with my wife, which is standard. And Karen's going to come and sing on Thursday. Karen, I look forward to that. Hopefully I can help you. And from there. All right, look, again, I know I've sort of repeated myself. I hope that was helpful. If anyone's got any specific questions or I didn't answer things I went too quickly, then just contact me and you can come make an appointment or social media. I'm still learning, obviously. I'm not a bad surgeon, but social media is still a bit beyond me. Cool. All right, and Julie, again, thank you. All right, team, good night. I'm going to say good night because truthfully I'm a bit tired. I'm operating tomorrow, so I better have an early night tonight. And hopefully I'll get to see some of you soon. All right, good luck with your journey. Great care. Bye.